So I would like to introduce Dr. Chien-Feng from Department of Pathology, Chien-Feng Medical Center, Taiwan. Title is Biomarkers in Cholangiocarcinoma. Please, Dr. Li.
Good morning, everyone. I'm so honored being here and to discuss some issues related to the biomarker in cholangiocarcinoma with all you. And everyone here knows that cholangiocarcinoma is a terrible disease. It accounts for 5 to 10% of all liver cancers and is the second most common liver tumor. For patients with unresected cholangiocarcinoma, the outcome is generally poor. So obviously, there are some unmet needs, including first, we need some early diagnostic biomarkers to enable more patients having curative surgery. And we also need some diagnostic biomarkers for individualized treatment plans. And when it comes to a biomarker, I think everyone knows CA99 and CA, which are two most commonly used serum biomarker, which can achieve a sensitivity and a specificity around 40 to about 90%. And of course, we have some modern biomarkers, some modern serum biomarkers, such as osteopontin, CYFRA 21-1, MMP7, and also a combination of these biomarkers to achieve a higher sensitivity and specificity. But as you may already notice that all these biomarkers had been developed on the basis to differentiate cholangiocarcinoma from non-cancer individuals. So it might have very limited clinical utility in the differentiation of tumor of unknown origin for its primary site. Of course, we have some molecular biomarkers such as SLP 411 and microRNAs, and also the circulating tumor cells. And of note, circulating tumor cells, although have a relatively low sensitivity, but it can be a useful biomarker in the prediction of patient outcome. For example, in a recent study published by Mayo Clinic, published in Hepatology, they identified a higher circulating tumor cell in the patient blood can be a very effective biomarker for the prediction of prognosis. And we, in our daily practice, can also identify circulating tumor cells from cholangiocarcinoma patients, such as shown here. The circulating tumor cells can be illustrated by DAPI for its nuclei, and they are positive for cytokeratin but negative for leukocyte common antigen. And in contrast, the white W cells are negative for cytokeratin but positive for leukocyte common antigen. So such study may be quite straightforward and can provide useful information in daily practice. Of course, we need some diagnostic tissue biomarkers. For example, in old men positive for HBV and HCV suffer from a solitary liver tumor. And the biopsy shows a tumor with a large polygonal morphology arranged in acinine or bread trabecular. The morphology feature lies between hepatocellular carcinoma and cholangiocarcinoma, and with a panel of immunohistochemistry, including CK19 and arginase 1 alpha-fetoprotein. On the right are two most commonly used biomarkers for hepatocellular carcinoma. So such immunoprofile can be very helpful in the differentiation of cholangiocarcinoma from hepatocellular carcinoma in daily practice. But again, it has very limited clinical utility in the workup of the primary site of a metastasis. So, and then we use users to be very interested in the gene expression profiling alteration in cholangiocarcinoma, and we provide a number of data sets such as that deposited by NCI on the GEO data set. And we noticed that compared with non-tumor epithelium, the cholangiocarcinoma tend to have more genes downregulated than up. And of the upregulated genes, they belong to cell adhesion, and many of them are related to cell cycle and mitosis, as well as cell division. And some of them are related to glycolysis. For example, the PKM2 and hexokinase 2 are significantly upregulated in cholangiocarcinoma. Of the downregulated genes, they belong to metabolism, especially that involving lipid metabolism. And of the genes, they include CL and the APO gene family. And you may also be interested about the copy number aberration in cholangiocarcinoma. From public domain dataset, we recomputerized and identified that copy number aberration is so infrequently identified in cholangiocarcinoma. And the most common copy number aberration is gene deletion involving chromosome 9p21.3, harboring CDKN2A and B, but the frequency is quite low, less than 10%, followed by the amplification of MDM2, ERBB2, and HER2, and MCL1, GINA, second D1, and also FGF and its ligand, FGFR3, and also the CMYC. And we, in our in-house case, can very occasionally identify the cases with ERBB2 gene amplification or EGFR gene amplification, but the ratio is quite low. So if we further look at the copy number aberration involving her gene family in cholangiocarcinoma, we can identify a very low instance of EGFR or HER2, ERBB3, or ERBB4 gene alteration, and most of them consist of gene amplification followed by missense mutation. So the gene amplification involving her family is infrequently identified in cholangiocarcinoma. And we further profiled the gene alteration from the 4 data set to see the frequent altered genes in cholangiocarcinoma. The data set includes that published by Memory Sloan Kettering Cancer Center, National Cancer Center Singapore, National University Singapore, as well as Johns Hopkins. And we learned that across all the 4 data sets, the most frequently altered genes is TP53, followed by ARID1A, as well as IDH and KRAS and FGFR2. And you may already notice that the FGFR2 gene alteration is mostly consists of gene fusion but not mutation. And there is a trend that TP53 alteration seems to be mutually exclusive with IDH1 gene mutation. So we further profiled, we further computerized to realize the co-occurrent or mutual exclusivity of these genes. And we learned that from the 4 data sets, the SMART4 and RNF43 gene alteration can be highly and significantly co-occurrent. And TP53 and SMART4 gene alteration can also be significantly co-occurrent. And as shown on the above slide, the TP53 and IDH1 alteration are significantly mutually exclusive. If we look at the individual data set for more detail, we can realize that the data set from National University Singapore that consists of almost 100% parasite-related cholangiocarcinoma can have very high ratio of TP53 and SMART4 mutation, but a very low ratio of IDH1 and IDH2 mutation. It seems that TP53 and IDH1 mutations are mutually exclusive and might associate with different etiologies. And if we further look at the published data, again, the cases from parasite-related cholangiocarcinoma has a very high frequency of TP53 and SMART4 mutation, and the IDH1 mutation is quite low. So the other database, such as that disclosed by Dr. Jiang Nairong, identify a lower TP53 and a SMART4 mutation and a relatively higher IDH1-2 mutation. I think none of this data is of parasite-related cholangiocarcinoma. So the different etiology might lead to a different mutation pattern in cholangiocarcinoma. And it's very lucky that we can validate some of the genetic alteration by immunohistochemistry in our daily practice, such as TP53, ARID1A, IDH, CDKN2AB, BRAF, P10, and also MMR proteins. For example, we can identify the totally negative staining of the tumor cells for P16 in a case with CDKN2A homozygous deletion. And in another case with P10 mutation, we can identify total loss of P10 expression in the tumor cells, but the endothelial cells can serve as a very beautiful internal control. Okay, and you may also be interested about the alteration pattern of some potential druggable mutations, such as BRAF mutation. If we cross over the public domain data, you can identify that a BRAF mutation can take place through the whole BRAF gene body. So the lack of hotspot can lead to a difficulty that is very difficult to detect the mutation by immunohistochemistry. We know we used to profile the mutation of BRAF by immunohistochemistry in melanoma and also thyroid cancer, but in cholangiocarcinoma, such strategy might not be useful. And the BRAF may be also altered by gene fusion. This is so complicated. And when it comes to FGFR2 gene alteration, as disclosed earlier, the most frequent alteration pattern is gene fusion. But beyond our image that there are so many fusion partners for FGFR2, that suggests it might be very difficult to screen all the fusion partners by means of RT-PCR. But how about FISH? The split apart FISH can be useful to detect gene fusion in some manner. But the FGFR2 is quite different because, as shown here, the FGFR2 might have so many fusion partners across whole genome, and some fusion partners might be of intrachromosomal translocation. FGFR2, BICC1, caspase7, and CCDC6, all the three fusion partners are within chromosome 10, the same as FGFR2. The intrachromosome translocation lead to a very little split apart distance of FGFR2, and it might not be easy to identify by split apart based FISH probe. So it seems that we need a complex RT-PCR array or NGS test to profile FGFR2 gene alteration. And next, how about the unchecked gene alteration? On the public domain data set, as I can see, none of the data set disclosed any case. No, there is no case on the public domain has unchecked gene fusion. To date, only one case reported by Anderson group, just only one of the 28 cases. So, is there no unchecked fusion in cholangiocarcinoma? Is there any assay difference? It's very lucky that I met Kai Wang yesterday, and I know he is an expert in gene profiling for cancer. I just asked, "Hi Kai, how many cholangiocarcinoma have you profiled?" And he said, more than 500. That's a great number to realize medicine. He said, including cases from US and China. So it might be a transethnic data. So I asked, great, how many of them harbor unchecked rearrangement? And his answer is zero. Yeah, it's zero. The answer seems to be very difficult. It's zero. So based on the solid data and also that from public domain, I think the unchecked gene rearrangement the frequency should be very low, around 1 out of 1,000 cases should be very low. And if we further look at the prognostic significance of selected gene alterations, first we profile the significance of TP53 alteration, and since that TP53 alteration is negative for prognostic significance. And how about the combination of TP53 and its most frequently co-occurring genes, including SMART4 and RNF43? It can reach a marginal significance in the prediction of poor outcome. And IDH1/2 mutation, again, tend to have a better outcome, but is not significant. However, the SMART4 alteration is predict for worse outcome, and so does CDKN2A alteration. Most of them are deletion. And PBRM1 as well as ROBO2 alteration are predicted for worse outcome. And although ROBO2 alteration seems to be predicted for worse outcome, but as you can see, the number is too small and the result becomes highly unstable. So to avoid this situation, we can combine a list of genes such as those involving cell cycle control into analysis. And with such strategy, we can get a signature with significant prognostic significance as shown here. And lastly, let's come to the immuno-oncology related biomarkers in cholangiocarcinoma. And a couple of months ago, I started to profile the mutation pattern in my in-house cases, and the case number is growing rapidly. And to date, I have more than 400 cases profiled. Of these cases, the organs expand through the whole body. And as you can see here, the tumor mutation burden the colorectal cancer as well as endometrial cancer can have very high tumor mutation burden. And two of the endometrial cancer harbor POE mutation, a hypermutatic genotype, and followed by cancer from renal pelvis and ureter. And the tumor from liver, including HCC and IHCC, as well as EHCC, and EHCC can have a relatively low mutation burden. And if we specify to see individual cancer type, we notice that cholangiocarcinoma usually harbor a low tumor mutation burden range from 0 to 8, with a median around 2. And hepatocellular carcinoma luckily may have a higher tumor mutation burden up to 24, and a median at 7 to 8. So the static result reach significance. So we can say that cholangiocarcinoma tend to have a very low tumor mutation burden. So that might not be ideal as a target for immuno-oncology as a sole treatment. And if we look at the STK11 and the B2M mutation, the two biomarkers are a negative biomarker for immuno-oncology. And again, the liver and the intrahepatic bile duct is almost negative for STK11 or B2M mutation. That's quite lucky. And the prostate is the most frequent. Prostate carcinoma is the most frequent to harbor STK11 mutation. So it's just a baseline data for your further consideration in the further planning of clinical trial. In conclusion, we learned that copy number change is less common in cholangiocarcinoma, and of them, chromosome 9p21.3 deletion is most frequent. And for some druggable genes, the aberration pattern could be quite complex. For BRAF, the lacking of hotspot makes it very difficult to design specific antibody. And for FGFR2, there are variant fusion partners make it almost invisible by using FISH and harder to be detected by using RT-PCR. So angiostatin should be considered. And we also learned various mutation patterns in those with different etiology, the parasite versus non-parasite lesion. So in conclusion, systemic genomic profiling is mandatory for the matching of treatment. In the next slide, I thank Professor Chen Lizhong and Jiang Nairong to contribute much domain knowledge and the member in my lab, as also as actor genomics. If you have further questions, you can send email or line me. Thank you.
Thank you very much. Wonderful lecture. So are there any comments and questions from audience? Okay, I have a question for you. So you mentioned about the etiology difference for biomarkers. So viral infection or flu infection influence biomarker expression in intrahepatic carcinoma?
Yeah. I have not analyzed the alteration pattern related to virus. Have not done yet because ongoing. The project is ongoing. Thank you.
So no.
I'd like knowledge currently.
Okay. Thank you. Oh, here.
Hi, this is Motonobu Bosada from Merck Serono, Tokyo, Japan. Allow me to ask a naive question. So, according to your presentation, gene amplification is relatively rare, like receptor tyrosine kinases, EGFR and FGFR and so on. Then my question is, in the case of gastric cancer, chromosome unstable group, it's have a high gene amplification, like an EGFR, HER2, FGFR2, and then those group has a high p53 mutations. It seems that in the case of cholangiocarcinoma, there is some p53 mutated group, but that is not correlated with some gene amplification. So then what makes those differences?
So the question is, in many cancer, the p53 mutation might have a positive correlation with gene alteration, copy number alteration, right? But it not seems to be such a story for cholangiocarcinoma. That's your question. So,
right.
Yeah, it's a very difficult question. I think in those with in general, those with T53 alteration lacking a clear-cut driving event. So for those, for example, the sarcoma usually harbor T53 mutation, but not the other mutation. And the only genomic aberration in sarcoma is gene amplification and deletion. And for lung cancer, T53 mutation is rare in adenocarcinoma, so the copy number change is infrequent. And in cholangiocarcinoma, I think there are other gene aberrations, such as FGFR2 driving mutation and also IDH driving mutation. And in these cases, I think the copy number aberration should be quite low. But I have not done subgroup analysis to see whether those with T53 mutation can harbor higher copy number change. I will check that soon. Thank you.
Thank you very much.
Another question? Okay, please.
Can you go back to the slides where you show the tumor mutation burden? I think it was one of the last few slides. Yeah. I think for the last few days, we've been talking about tumor mutation burden as if it's a good biomarker for immunotherapy. But you look at your colorectal cancer, historically, we know it has high tumor mutation burden, but only the one that harbor MSI responded. I think for us to check tumor mutation burden and make it a good biomarker doesn't make a whole lot of sense. We check TBM at one spot, like I take a picture. But we know by nature, when tumor progress, they accumulate more mutation. So if we just wait until everybody get very advanced, their tumor mutation burden will increase. And that has been shown by multiple case reports. Even one published some literature show that tumor mutation gradually get more and more as disease progresses. But we don't see people with advanced disease respond better to immunotherapy. So I'd like the audience to think about this. I don't think tumor mutation burden really is a good biomarker. That's my opinion.
Yes, I agree with your opinion. Partly, yeah. Since if you look at the endometrial cancer, many endometrial cancer can have very high tumor mutation burden due to the mutation involving POL family, such as POL-E. The hypermutation type is not indicated for immunotherapy, but it can have very high tumor mutation burden, as you said. And for some cases, the hypermutation does not link to the presentation of neoantigen on the cell surface. So the hypermutation might not also correlate to the response to immunotherapy well, but only in a subgroup. The tumor mutation burden can correlate to the presence of neoantigen, can be response to immunotherapy.
Yeah, you look at the kidney, doesn't have a good, very high tumor mutation burden, but we know kidney cancer respond to immunotherapy very well. Lung cancer has very good data for immunotherapy. Their overall tumor mutation burden is not high.
Yeah, yeah. Thank you.